Hi everyone, this is Dr. Franks, and today I'm going to discuss oral and otic disorders, which corresponds to chapters 29 through 31 in your book. After viewing this lecture, you should be able to recognize exclusions to self-care and circumstances that warrant referral for otic and oral disorders, understand the etiology and pathophysiology of otic and oral disorders, identify oral and otic disorders based on patient presentation, and recommend appropriate pharmacologic and non-pharmacologic treatments accordingly. You should be able to provide patient counseling for treatments recommended to patients, including but not limited to proper administration of ear drops and proper toothbrushing and flossing technique. Please know the dosing for carbamide peroxide and anhydrous glycerin used for impacted cerumen and isopropyl alcohol and anhydrous glycerin used for water-clogged ears. Also know the max duration of OTC use for all treatments for which it was mentioned. First, we will discuss otic disorders, including excessive or impacted cerumen and water-clogged ears. Exclusions to self-treatment for otic disorders include inflammation or signs of infection, pain that is severe associated with discharge or develops during self-treatment, bleeding or signs of trauma, presence of tympanostomy tubes or ruptured tympanic membrane, ear surgery within the past 6 weeks, patients incapable of following proper instructions, hypersensitivity to recommended agents, age less than 12 years, or symptoms that do not resolve after 4 days of appropriate treatment. First, we will discuss excessive or impacted cerumen. Cerumen is made from oily secretions from the exocrine glands that mix with fatty fluids from the apocrine glands. It is found on the skin on the outer half of the external auditory canal. Cerumen production is not a pathological condition. Instead, it lubricates the external auditory canal, traps dust and foreign materials, and provides a waxy waterproof barrier to the entry of pathogens. It contains various antimicrobial substances and has an acidic pH, which also aids in the inhibition of bacterial and fungal growth. Normally, cerumen slowly migrates outward with jaw movements that occur when eating and talking. It may become impacted in people with abnormally narrow or misshapen external auditory canals, excessive hair growth in the canal, overactive ceruminous glands, as well as those with hearing aids or who wear earbuds or earplugs frequently. Older adults also experience impacted cerumen as a result of atrophic ceruminous glands. Dry cerumen is harder to expel. Patients with excessive or impacted cerumen may complain of fullness or pressure in the ear. They may experience a gradual loss of hearing, vertigo, tinnitus, chronic cough, or mild pain. The goals of treatment are to soften and remove the cerumen and resolve their symptoms. Frequent removal and proper cleanser of ear devices, such as hearing aids and earbuds, may help prevent wax buildup. A wet washcloth draped over a finger is the safest way to remove cerumen from the ear and prevent impaction. Most people use cotton swabs to clean cerumen from their ears, but they actually push the cerumen into the ear further, increasing risk of impaction. There is one pharmacologic agent for removal of impacted cerumen. Carbamide peroxide 6.5% and anhydrous glycerin may be used in adults and children 12 years of age and older. There are other agents that have been used by physicians or by patients as inexpensive home remedies, such as mineral oil, but there is no data to support their efficacy. There are a few complementary therapies as well, but there are no studies on these products at all, so the safety and efficacy of the products for this purpose is unknown. Ear candles are not recommended for use by the FDA because of serious ear injuries that have occurred in patients using them. A hollow candle is burned with one end inserted into the ear canal. It is supposed to create a negative pressure and draw cerumen from the ear, but studies show it's not effective. Carbamide peroxide acts as a weak antimicrobial, and it mechanically breaks down the cerumen and helps loosen it. The glycerin softens the cerumen. These products are safely to apply to abraded skin, and they may be used twice daily for up to 4 days. The proper procedure for using carbamide peroxide eardrops is as follows. First, the patient should wash their hands. Next, they should inspect their medication to ensure the medicine is correct and the dose is correct and that the medication is not expired. Next, remove the dropper cap. The patient should lie down or tilt their head so that the affected ear is facing up. Adults should pull their earlobe up and back to open the ear canal. Children less than 3 should tilt the affected ear up and pull the ear back and downward. Place 5 to 10 drops of medication in the ear canal. Do not touch the applicator to the ear to prevent contamination. Keep the ear tilted up for 5 minutes so the medicine can run to the bottom of the ear canal. A cotton swab may be used to prevent leaking. Any remaining wax may be removed by gently flushing the ear with warm water using a soft rubber bulb ear syringe. Replace the cap and wash hands again. I mentioned that the remaining cerumen could be removed by flushing the ear with warm water. The proper procedure is as follows. Fill the bulb syringe with warm water. Do not use hot or cold water. Hold a container under the ear to catch the water and tilt the head to the side. Gently pull the earlobe down and back to expose the ear canal. Place the opening of the syringe into the canal with the tip pointed slightly upward towards the side of the ear. Squeeze the bulb gently to introduce solution into the canal. Ensure all water is drained to prevent causing an infection. Rinse syringe thoroughly before and after each use and allow it to dry. Consult a provider if pain or dizziness occurs or cerumen remains in the ear after using the medication twice daily for 4 days. This is the treatment algorithm for assessment and treatment of patients with symptoms of impacted cerumen. Now we will discuss water-clogged ears. Water-clogged ears is water trapped in the ear canal. It is not the same as swimmer's ear, which is otitis externa. Otitis externa is a painful inflammatory condition that should not be self-treated. Patients with water-clogged ears may feel wetness or fullness in their ear and they may have reduced ability to hear. It may be caused by humidity, swimming, or bathing. If the water remains in the ear canal, it could result in maceration of the tissue leading to infection. This is something retail pharmacists encounter frequently living in Florida. The goals of treatment are to dry the ear, thereby preventing infection. I mentioned earlier that patients with a tympanostomy tube or ruptured tympanic membrane are not candidates for self-treatment. Ear drying agents will cause pain in these patients, thus they should be referred to their provider. Regarding non-pharmacologic treatment options, patients can expel water from their ears immediately after swimming, bathing, or sweating excessively by tilting their ear downward and pulling on the top of their ear. A blow dryer may be used as well, but it must be on low, not high, and it should not be pointed directly into the ear. Lastly, there are water-absorbing earplugs available for patients 17 years of age and older. They are only to be used once for 5 to 10 minutes to absorb trapped water and then discarded. Patients should be counseled to keep the earplugs out of reach of small children and pets due to risk of choking. There is one pharmacologic ear drying aid approved by the FDA, isopropyl alcohol and anhydrous glycerin. The alcohol dries the ear, and the glycerin prevents the alcohol from causing over-drying. An acetic acid mixture can be made at home. It is made by mixing equal parts of white vinegar and 95% isopropyl alcohol. If the skin is abraded, it may cause stinging. Both treatments may be used by pregnant and lactating women and elderly patients. Children under 12 years of age, however, must be referred for medical care. The most common complaints of ear disorders are pain, itching, and hearing loss. Determining what disorder is causing the symptoms is key to making an appropriate recommendation. This chart shows the specific symptoms of different otic disorders to assist with differentiation between the disorders. Patients with disorders listed in this chart should be referred for medical care unless it is thought to be due to water-clogged ears, impacted cerumen, or motion sickness, because those disorders can be self-treated in patients without exclusions to self-care. This is the treatment algorithm for assessment and treatment of patients with symptoms of water-clogged ears. That concludes the otic disorders. These are the oral disorders we will discuss. Prevention of hygiene-related oral disorders. Our first topic is prevention of dental caries. First, we will discuss prevention of dental caries or cavities. Dental caries are an infectious disease that affects the calcified tissues of the teeth. The carious process is characterized by alternating destruction or demineralization and repair or remineralization. Plaque bacteria generate acid from dietary carbohydrates, and the acid demineralizes tooth enamel and dentin, leading to soft carious lesions. Carious lesions start slowly on the enamel surface and initially produce no symptoms. Once demineralization progresses to the softer dentin, the carious lesion becomes clinically or radiographically evident. Patients may now experience pain and sensitivity to stimuli or chewing. If left untreated, the dental pulp can become damaged and eventually necrotic. The goals are to promote good oral hygiene practices, which will prevent the buildup of plaque and the development of caries. We will discuss various non-pharmacologic and pharmacologic measures for preventing the buildup of plaque in order to prevent dental caries. Dietary changes aimed at reducing cariogenic foods, such as foods high in sugar and those that stick to the teeth after chewing, is thought to be helpful in preventing caries. Instead, one should eat less cariogenic foods or foods high in water content, such as fresh fruit, foods that stimulate saliva flow, such as high-fiber foods that take longer to chew, and foods high in protein. Devices such as toothbrushes and floss play an integral role in removing plaque. There are other devices that can be used in conjunction with brushes and floss, such as oral irrigators and Proxa brushes, which help to remove plaque from in between teeth. Patients should be counseled on the correct technique for brushing and flossing because a lot of patients are making mistakes which could reduce the effectiveness. The best time to brush is after meals because it will remove the carbohydrates which feed the plaque from the teeth. If patients cannot brush after each meal, they should at least brush twice a day for 2 minutes at a time. It should be done in a systematic manner. For example, the mouth can be separated into 4 quadrants: upper left, upper right, lower left, and lower right. Patients should brush each quadrant for 30 seconds each. Patients should also brush the upper surface of their tongue. When brushing, they should use a gentle scrubbing motion with the tips of the bristles at a 45-degree angle against the gum line. Patients should avoid brushing too hard because it can cause gingival irritation and recession, leading to tooth hypersensitivity. Once the patient is finished brushing, they should rinse their mouth with water and spit. For children under 2, rather than brushing, caregivers can clean their teeth with a soft cloth and massage the gums. Consult a dentist before using fluoride toothpaste in children under 2 years of age. Only regular strength toothpaste should be used for children ages 2 to 6 years old. For preschool children, caregivers should apply a pea-sized amount of toothpaste to a child-sized toothbrush and brush the teeth until they can brush properly. Children should be taught how to rinse their mouth with water and spit to avoid swallowing fluoride. The proper technique for flossing is as follows. Pull out 18 inches of floss and wrap it around the middle finger. Wrap the remaining floss around the middle finger of the opposite hand, leaving about 1 inch of floss in between. Use a gentle sawing motion to guide the floss to the gum line as seen in the picture on the left. Then curve it into a C shape against one tooth and slide the floss into the space between the gum and the tooth as seen on the picture on the right. Hold the floss tightly against the tooth, then repeat the process for the rest of the teeth. Fluoride is used to prevent the development and reverse early carious lesions. Fluoride is available in mouth rinses, gels, and toothpaste. Fluoride is also found in tap water in many cities across the U.S. The safety and efficacy of systemic fluoride is very controversial, although your book is pro-fluoride. The amount of fluoride found in rinses and toothpaste can be toxic if swallowed, especially by children. Children under age 12 should be supervised when using a topical fluoride product until the caregiver is sure the child is using proper technique. Fluoride rinses and gels should not be used unless directed by a dentist in children under 6. Proper administration technique for fluoride rinses and gels is as follows. First, brush teeth with a fluoride dentifrice or toothpaste. If using a rinse, measure out the recommended dose and swish vigorously in the mouth and between the teeth for 1 minute. If using a gel, brush the gel on the teeth and leave it on for 1 minute. After 1 minute, spit. Do not swallow the fluoride. Refrain from eating, drinking, or smoking for 30 minutes. Use only once daily. Dentifrice or toothpaste is used with a toothbrush to enhance removal of plaque and stains, reducing dental caries and gum disease. Dentifrice is available in paste and gel and commonly contains an abrasive, surfactant, humectant, binder, sweetener, flavoring agents, and a therapeutic agent such as fluoride. Tartar-controlled dentifrices contain anti-calculus or tartar control compounds. Reducing tartar is considered non-therapeutic, meaning it may not add additional benefit in prevention of caries. Whitening dentifrices are also considered non-therapeutic and may contain higher concentrations of abrasives and should not be used long-term or used by patients with exposed root surfaces. There is one anti-plaque gingivitis dentifrice. It contains fluoride and triclosan as an antibacterial agent. It is sold under the brand name Colgate Total. Triclosan has actually been shown to disrupt the endocrine system and has been removed from all other toothpaste brands. It is not intended for children under age 6. I personally do not recommend the use of any products containing triclosan. Mouth rinses may be used adjunctively to flossing and brushing with a fluoride toothpaste. Most mouth rinses contain fluoride and thus should not be used in children less than 6. There are 3 categories of mouth rinses. Cosmetic mouth rinses do not contain antimicrobial or other therapeutic agents. They freshen the breath and clean some debris from the mouth. It is important to note the potential for breath-freshening mouth rinses to disguise or delay the treatment of pathological conditions that may cause bad breath, such as periodontal disease and other oral or respiratory infections. If the odor persists after toothbrushing, the patient should be referred to a dental provider. Therapeutic mouth rinses do contain antimicrobial or other therapeutic agents and thus have anti-plaque or anti-gingivitis activity. Rinses containing phenol oils, methyl salicylate, and alcohol may cause sloughing of the oral epithelium. Mouth rinses generally may cause burning and irritation. If the irritation persists after discontinuing, the patient should seek medical care. Most rinses contain alcohol. Accidental ingestion in children could cause intoxication and could possibly be fatal. Mouth rinses containing 3 grams or more of alcohol per package are required to use child-resistant packaging and should not be used in children less than 12. If a patient comes to you for a product recommendation, you should assess their current dental practices. Do they meet current standards? Do they see a dental provider at least every 6 months? Do they have a history of caries or a new carious lesion? You can then make recommendations accordingly. Because we are talking about prevention of dental caries, there are no traditional exclusions to self-treatment. You should, however, be able to counsel patients on when to seek medical care. Children swallowing alcohol or anyone swallowing fluoride products should be referred for immediate medical care. Patients with tooth pain should also be referred because it is a sign of a carious lesion that has progressed beyond the initial reversible stages. Patients with bleeding, swollen, or red gums should be referred for medical treatment as well. Lastly, patients should be referred if they develop a mottled appearance on the surface of their enamel because it is a sign of dental fluorosis. This tends to appear in children due to too much fluoride. You can see the fluorosis example in the picture. Our next topic is prevention of gingivitis. Gingivitis is inflammation of the gums. It is an early form of periodontal disease and is reversible. If it is not treated properly, it will likely progress to more severe periodontal disease, which can lead to tooth loss and irreversible alveolar bone loss. Marginal gingiva is held to the tooth by collagen fibers. Microorganisms and plaque release acids and toxins that damage the tissue. Dilation and proliferation of the capillaries increase blood flow, leading to swollen, puffy appearance. There are several factors, as you can see on the slide, that may increase a patient's risk of developing gingivitis. The early stages of gingivitis is marked by gingival erythema, as you can see in the picture. As the disease progresses, there are further changes in the size, color, and shape of the gingiva. Prevention and reversal of early gingivitis consists of calculus prevention and control of plaque, so the methods are the same as prevention of caries. Good oral hygiene, including brushing at least twice daily for 2 minutes and flossing at least once daily. Dentifrice, mouth rinses, and topical fluoride may offer additional benefit. Patients should be referred to a dental provider if their teeth bleed while brushing or if they do show signs of gingivitis. Both oral and systemic conditions may cause halitosis or bad breath, but it is most often due to poor oral hygiene. Most bad breath occurs because of a breakdown of sulfur-containing proteins into volatile sulfur compounds, or VSCs. Xerostoma, or dry mouth, may also cause halitosis. Medications that cause dry mouth, such as anticholinergics, may indirectly cause halitosis. Proper oral hygiene, including brushing the teeth and tongue, is recommended to prevent halitosis, even if it is due to a medical condition. A tongue cleaning device, such as a scraper, may be used. One of the primary sites for the formation of VSCs is the back of the tongue, so cleaning it with a tongue scraper will remove the VSCs and prevent them from spreading to the tonsils. Mouth rinses containing zinc chloride and chlorine dioxide are the most effective chemical prevention of VSCs. Smart Mouth Rinse is a product available that contains both ingredients. Patients with severe halitosis or halitosis that does not resolve with treatment should be referred to their provider. Our next topic is prevention of hygiene-related denture problems. Denture stomatitis is a hygiene-related problem in people with partial or full dentures. It is also referred to as denture sore mouth and chronic atrophic candidiasis and may be attributed to infection with Candida albicans. Patients with denture stomatitis have inflammation on the entire denture area as compared to localized pain from ill-fitting dentures. The inflamed denture-bearing area may appear granular, erythematous, edematous, and with sores or a burning sensation. Good denture hygiene is key to preventing denture stomatitis. Dentures should be cleaned at least once daily to remove stains, debris, and potentially harmful plaque. A regimen of brushing, then soaking, then brushing again is more effective in removing plaque and bacteria. Dentures should be brushed with a paste or powder made specifically for dentures. It is applied with a specialty brush designed to adapt to the denture's contour. Patients should be counseled not to scrub vigorously to prevent damaging the denture. The paste or powder must be thoroughly rinsed before inserting the denture back into the mouth in order to prevent irritation of oral tissue. Recommend against the use of household cleaners or whitening toothpaste to clean dentures. They are ineffective and may damage the denture material. There are various chemical cleaners in which dentures may be soaked. The frequency and duration of soaking depends on the type of chemical. All chemical cleaners must be rinsed thoroughly before inserting to prevent irritation and chemical burns. If a patient comes to you for a product recommendation, you should assess their current denture hygiene practices. Is their current denture care appropriate? Are they suffering from ill-fitted dentures or denture stomatitis? If so, they should be referred to a dentist. A dentist should also evaluate stains that remain on dentures despite proper brushing and soaking. We will now discuss oral pain and discomfort. First, we will discuss tooth hypersensitivity. Tooth hypersensitivity occurs when stimuli such as hot or cold foods or beverages reach the nerves under the tooth and cause pain. Harsh brushing with an abrasive toothpaste or hard bristle toothbrush may cause hypersensitivity. Dental procedures such as deep scaling, root planing, or orthodontic tooth movement may cause temporary hypersensitivity. Tooth whitening toothpastes contain higher amounts of abrasives and may result in hypersensitivity. Bruxism or jaw clenching and teeth grinding may also cause hypersensitivity. Patients with tooth hypersensitivity may experience a quick, sharp pain when hot, cold, sweet, or sour solutions or hot or cold air touches the tooth. The pain varies from mild to excruciating depending on the patient. The treatment goals are to stop abrasive toothbrushing and repair damaged tooth surfaces using an appropriate toothpaste. When assessing patients for tooth hypersensitivity, the main objective is to differentiate between toothache and hypersensitivity. Patients with toothache should be referred to a dentist as soon as possible. Other exclusions to self-care include mouth soreness associated with poor-fitting dentures, presence of fever or swelling, loose teeth, bleeding gums in the absence of trauma, broken or knocked out teeth, severe tooth pain triggered or worsened by hot, cold, or chewing, and trauma to the mouth with bleeding, swelling, and soreness. Non-pharmacologic treatment includes eliminating predisposing factors. If patients are brushing harshly with a medium or hard bristled brush and an abrasive toothpaste, they should switch to a soft bristled brush and a regular fluoride toothpaste. Abrasive whitening toothpaste should be avoided. Oral fluoride formulations may also be used. Patients should avoid brushing their teeth for 2 to 3 hours after eating acidic foods. If regular fluoride toothpaste is not successful in reducing hypersensitivity, patients can use a desensitizing toothpaste. Desensitizing toothpastes can also contain fluoride and are highly effective in reducing discomfort. They are used in the same way as other toothpastes, except patients should not rinse their mouth with water after brushing. Some patients require long-term therapy beyond a few weeks. If a patient's symptoms continue beyond 4 weeks, the patient should be referred to a dentist for evaluation. This is the algorithm used to assess and treat patients with tooth hypersensitivity. Our next topic is teething discomfort. Teething is the eruption of the deciduous or baby teeth through the gingival tissue. Not all babies suffer discomfort during teething, but there are many symptoms associated with teething other than pain. Babies may experience irritation, reddening, excessive drooling, mouth biting, gum rubbing, low-grade fever, slight swelling of the gums, sleep disturbances, and irritability. Teething is not associated with vomiting, diarrhea, nasal congestion, malaise, fever, or rash. Eruption cysts may be present. They are bluish, soft, round swellings that form over emerging incisors or molars. They are usually harmless and should be left alone. 3 bumps on the biting surface of the emerging incisors, called mammalians, may be present as well. Teething usually begins around age 6 months, and each tooth eruption usually occurs over an 8-day window. The goals of treatment are to relieve pain and reduce irritability and sleep disturbances. When assessing patients, it's important to distinguish between teething and infection. It would help to inspect the child's gums if they will allow you to do so. Non-pharmacologic measures to reduce teething discomfort include massaging the child's gums, allowing them to chew on a teething ring or a cold wet cloth, or if the baby is eating solid foods, they can chew on hard foods, for example, a celery stick. Topical anesthetics can be used to temporarily numb the area. Only products marketed for infants should be used, and the infant must be at least 4 months old. The medication is rubbed on the baby's gums up to 4 times daily. Parents should make sure their product is alcohol-free. Systemic analgesics such as acetaminophen may be used as well. Babies with uncharacteristic symptoms such as vomiting, diarrhea, nasal congestion, malaise, pain, or symptoms that are not relieved after 3 to 5 days of treatment should be referred for medical care. Our next topic is recurrent aphthous stomatitis, or RAS. Recurrent aphthous stomatitis, or RAS, are recurrent lesions referred to as canker sores. The cause of the lesions is unknown, but the most likely precipitating factors are stress and local trauma. Trauma could be caused by chemical irritation, biting of the inside of the cheek or lips, or injury from brushing or braces. There is a genetic component. More than 42% of patients with RAS have a first-degree relative with it. Other precipitating factors include food allergies, hormonal changes, nutritional deficiencies, irritable bowel syndrome, and HIV or AIDS. RAS lesions occur on non-keratinized mucosal surfaces on the tongue, the floor of the mouth, the soft palate, or inside the lining of the lips and cheeks. The lesions are round or oval with a flat or crater-like appearance and are grayish-yellow in color. They are very painful, and the pain increases when eating, drinking, and may inhibit normal eating, drinking, talking, swallowing, and routine oral hygiene. The goals of treatment are to relieve the pain and prevent infection. Patients should be referred for medical care if they have lesions associated with underlying pathology, symptoms of systemic illness, lesions lasting more than 14 days, or their symptoms do not improve after 7 days, frequently recurring lesions, and failure of prior appropriate self-treatment. If the patient has nutritional deficiencies, then they should increase their dietary intake of those nutrients or begin taking a supplement. If the patient has a food allergy thought to be a contributing factor, then they should avoid that food. Spicy, acidic, and sharp foods should be avoided until ulcerations improve. Ice may be applied directly to the lesion for temporary relief in 10-minute increments, but no longer than 20 minutes per hour. Heat should be avoided due to risk of spreading infection if present. Because stress can be a factor, relaxation can be effective in reducing ulcer frequency. Silver nitrate should not be used on lesions. It is not effective and may stain teeth and damage healthy tissue. There are several types of pharmacologic therapies for the treatment of RAS. The treatments reduce the symptoms, but they do not prevent recurrence. Table 31.5 lists several brand name products. Oral debriding and wound cleansing agents may be used to cleanse the ulcer and provide temporary relief of discomfort. A few drops is applied to the lesion and allowed to remain in place for 1 minute. As a rinse, carbamide peroxide drops are placed on the tongue, mixed with saliva, and switched in the mouth for 1 minute. The 3% hydrogen peroxide should be mixed with equal parts water before rinsing the mouth, but the 1.5% hydrogen peroxide products should be used without dilution. Topical oral anesthetics numb the area. They contain benzocaine, menthol, phenol, phenolate sodium, and benzyl alcohol. To reduce the risk of irritation, patients using topical anesthetics should be counseled to avoid dentifrices containing sodium lauryl sulfate. Topical oral protectants such as canker cover are used to create a barrier to protect the area, decrease friction, and temporarily relieve symptoms. Some products are available in combination with an oral anesthetic, and they can be applied 3 to 4 times daily. Rinsing the mouth with Listerine antiseptic rinse may speed up the healing time of ulcers. A saline rinse or a baking soda paste may also be used for a few minutes to soothe ulcers before applying a medication. Systemic analgesics such as NSAIDs or acetaminophen may also be taken for pain relief. Patients with RAS should be counseled to only use debriding and cleansing agents over the counter for 7 days and not to swallow the medication. If they take aspirin, It should not be held in the mouth or placed directly on the lesion to prevent tissue damage. Recommend against the use of silver nitrate for RAS. To reduce the risk of irritation, patients using topical anesthetics should be counseled to avoid dentifrices containing sodium lauryl sulfate. When assessing patients, attempt to identify and then remove any precipitating factors. Also, assessing the effectiveness of previous self-treatments can help your therapy recommendation or discern whether the patient should be referred. Patients whose symptoms worsen or do not improve after 7 days of treatment should be referred.
Our next topic is minor oral mucosal injury or irritation.
Minor mucosal injury or irritation includes minor wounds that can result from dental procedures, accidental injuries such as biting the tongue or cheek, or abrasions from sharp foods. The wounds may be inflamed and painful. The goals of therapy are to control the patient's discomfort, aid in healing the wound, and prevent the development of secondary bacterial infections. The exclusions for self-treatment include toothache or severe mouth pain, mouth soreness associated with poor fitting dentures or orthodontic appliances, fever, loose teeth, bleeding gums without trauma, broken or knocked out teeth, severe tooth pain triggered or worsened by hot, cold, or chewing, trauma to the mouth with bleeding, swelling, and soreness. Ice may be applied to bruised lips, cheeks, or palate to reduce swelling. It should be applied in 10-minute increments, but no longer than 20 minutes per hour to prevent local tissue damage. Sodium bicarb solutions, as discussed in the treatment of canker sores, can act as an oral debriding wound cleansing agent. Saline rinses, also discussed in the treatment of canker sores, can clean and soothe the wound. Pharmacologic therapies are also similar to RAS. Topical oral anesthetics and protectants and oral debriding wound cleansing agents can be used to treat minor oral mucosal injury. Patients should be counseled to recognize the symptoms of infection. If they are taking aspirin, they should be counseled to not hold it in their mouth or directly on the lesion. Direct contact with aspirin may cause chemical burn and tissue damage. Patients with mucosal irritation should avoid products containing substantial amounts of menthol, phenol, or camphor due to the risk of tissue irritation and damage or systemic toxicity. Patients should be referred for medical care if their symptoms persist 7 days after treatment or 10 days from the onset of the irritation or injury. They should also be referred if their symptoms worsen during treatment or if they develop symptoms of systemic infection.
Our next topic is herpes simplex labialis.
Herpes simplex labialis lesions are also referred to as cold sores and fever blisters. They are caused by the herpes simplex virus 1 and are highly contagious. The virus is transmitted through direct contact with fluids from the vesicles or by contact with objects contaminated with the virus. Once infected, the person has the virus for life. The virus has periods of dormancy and reactivation. Reactivation may be caused by a number of triggers, for example, exposure to sunlight or cold, and stress or fatigue. Herpes lesions typically occur on or around the lips. The lesions are small red papules of fluid-filled vesicles. They are painful, and patients tend to be embarrassed by their appearance. The development of lesions is often preceded by a prodromal phase consisting of symptoms of burning, itching, tingling, and numbness in the area in which the lesion develops. Mature lesions often develop a scab or crust over the lesion. The rate of recurrence and the extent of the lesion vary greatly from person to person. The goals of therapy for herpes simplex labialis include relieving the pain and irritation, preventing the spread of lesions with the patient themselves as well as to other people, and preventing secondary infections. Patients are not candidates for self-treatment if their lesion has been present for more than 14 days, if they have had an increased frequency of outbreaks, if they have immunosuppression, or if they have symptoms consistent with an infection such as fever, swollen glands, or rash. The treatment of herpes simplex lesions is similar to that of RAS. Patients should clean the lesion with mild soap and wash their hands to prevent contaminating surfaces, which could infect other people or reinfect themselves. They should keep the lesion moist to prevent drying and cracking, which reduces the risk of developing a secondary bacterial infection, improving healing and reducing discomfort. They should avoid precipitating factors to prevent recurrence. For example, if sun exposure is identified as a precipitating event for a patient, recommend the patient avoid the sun or use sunscreen on their lips and face. Topical skin protectants help protect lesions from infection, relieve dryness, and keep the lesion soft. Topical anesthetics help reduce burning, itching, and pain. Docostinol is the only FDA-approved OTC product proven to reduce the severity and duration of symptoms. Systemic analgesics may be used to provide additional pain relief. There are several complementary therapies that have been used to treat herpes simplex labialis. Tea tree oil has been shown to reduce healing time similar to that of topical acyclovir. Lysine has preventative effects and has been shown to decrease frequency of outbreaks when taken daily. Longo Vital is a dietary supplement that includes vitamins A, B, C, D, and E, as well as paprika, rosemary, peppermint, hawthorn, pumpkin seeds, and yarrow flowers. It has been shown to decrease the number, duration, and size of lesions after 2 months of treatment. Lemon balm has been shown to reduce symptoms, shorten healing time, and prevent spreading of lesions. Patients should be counseled on measures for preventing the spread of highly contagious lesions, such as washing their hands frequently. They should not apply hydrocortisone to herpes lesions. If a secondary bacterial infection develops, a thin layer of triple antibiotic ointment may be applied to the lesion 3 to 4 times daily. If the patient is using a product that contains camphor or menthol, the concentration should not exceed 3% for camphor or 1% for menthol. Patients should be referred to a dentist for lesions that do not heal within 14 days if self-treatment does not relieve their discomfort, or if their symptoms change or worsen, or if they develop symptoms of a systemic illness such as fever, malaise, rash, and swollen lymph glands.
Our last topic is xerostomia.
Xerostomia is dry mouth due to little or no salivary production. Patients with certain disease states are prone to xerostomia. Radiation treatment of the head and neck, for example, can cause atrophy of the salivary glands, and most patients have compromised salivary function for the rest of their lives. Medications, such as anticholinergic drugs, can also cause dry mouth, as I mentioned when we discussed halitosis. Xerostomia can result in difficulty talking or swallowing, stomatitis, burning tongue, halitosis, lack of appetite that can eventually cause a decline in nutritional status, hypersensitivity of the teeth. It can increase the incidence of dental caries despite excellent oral hygiene, and it can disrupt the normal flora in the mouth, leading to candidiasis. Patients with any of the following exclusions to self-treatment should be referred for medical care: tooth erosion, decalcification and decay, candidiasis, gingivitis, and periodontitis, reduced denture wearing time, mouth soreness associated with poor-fitting dentures, presence of fever or swelling, loose teeth, bleeding gums in the absence of trauma, broken or knocked out teeth, severe tooth pain triggered or worsened by hot, cold, or chewing, and trauma to the mouth with bleeding, swelling, or soreness. The treatment goals for xerostomia include relieving the discomfort caused by dry mouth, reducing the risk of dental decay, preventing and treating infections and periodontal disease that may develop as a result of the condition. Non-pharmacologic therapy includes avoiding substances that reduce salivation, such as smoke or smokeless tobacco, and alcohol, including mouth rinses. Taking medications that may cause dry mouth 1 hour prior to meals may also be beneficial because eating stimulates salivation. Patients should discontinue medications that cause dry mouth if possible. They should also limit their intake of sugary and acidic foods to prevent tooth decay. Counsel patients not to suck on hard candies that contain sugar. You can, however, recommend chewing gum that contains sugar alcohols rather than sugar-containing gum to stimulate the saliva flow. Patients with xerostomia should increase their water intake, and they should use very soft toothbrushes to minimize tooth abrasion. Artificial saliva products are the primary agents for relieving the discomfort of dry mouth. They are designed to mimic natural saliva but do not contain the protective components. No product has demonstrated the ability to remineralize enamel. Most products are available as a spray, but there are gels available as well. The products may be used at any time. The minimum suggested use is after meals and at bedtime. Patients on low-sodium diets should avoid products that contain sodium. I think I have already discussed most of these counseling points already. Patients should be referred to a dentist if their symptoms do not improve or if they worsen. That concludes the lecture. Thank you.